Until a few years ago, the role of immune system was considered a kind of side or a less important aspect of MDS pathophysiology. We were thinking, well, there are some immune dysregulations in MDS, but are they actually pathophysiologically important, or they are a consequence of other things that are happening? In recent years, we have noticed that not only immune system is important in terms of initiating of the disease or potentially contribute to pathophysiology of MDS. Also, presence of other autoimmune diseases or chronic inflammation has a very direct correlation with the risk of both MDS and AML. Particularly in past few years, focus been on the role of activation of myeloid-derived inflammation and basically NLRP3 pathway related pathways that are activated in MDS, and we have this myeloid-derived continuous inflammation. So that is one aspect. The other aspect is how in MDS the overall immune response in terms of cellular immune response changes from a more active immune response, cellular immune response in lower risk MDS to higher risk MDS, which is very much immune suppressed, similar to other tumor that we see in human or in animal models. To summarize, this aspect is our understanding of immune system in higher risk MDS has changed in recent years. We know much better now that we have a background inflammation and inflammatory response, which is very much NLRP3 related, and we have this background inflammation continues and contributes to the somatic mutation, and some of the somatic mutation also contribute to this inflammation. So it's a mutual connection between inflammation, genomic instability, and presence of some somatic mutation and inflammation. This presence of long-standing inflammation not only leads to genomic instability, in longer term affects cellular immune response. When your T cells, for instance, are exposed to long-standing inflammation, in longer term they become exhausted and they go through cell death or become anergic and non-functional. So the immune surveillance which is necessary in MDS to eradicate or at least keeping check the malignant clone may become ineffective. Also, there are recent publications to show that specific mutations like TP53 mutation could lead to overexpression of some of the immune checkpoints, and this overexpression of, for instance, PD-L1 may prevent an effective immune response. Other cells also, NK cells, B cells, etc., they will be affected in the long-standing inflammation and potentially in high-risk MDS. And when you have all of these, the environment is inflammatory, so we have inflammation contribute to genomic instability and disease progression, and you don't have an immune response which is necessary for keeping the mutated clone on the check. And this combination is very unhelpful in a patient and may lead to a quicker progression towards AML and make the situation worse than what it is. So immune system is not considered a consequence of MDS anymore, although genomic instability and MDS itself, when the disease progress, affect the immune system, but also immune system contribute to the pathophysiology of MDS. How this inflammation happens, what is the initiating factors, how environmental factors affecting this for instance, how microbiome may affect the inflammation. Are there any other factors that contribute into this inflammatory environment? These are the questions that we don't know. When you have this inflammation and presence of low-level somatic mutation, for instance, when you have CHIP and inflammation, is it more likely to contribute to a more severe type of MDS if patient gets MDS later on? These are the questions that we don't know the answer, and still, or not completely, there are evidence for different contribution and how immune system and somatic mutation may help each other to make the MDS higher risk. But still ongoing studies trying to answer this question, and more studies are also needed.